It's a pleasure to be part of this Zoom call dealing with the issue of, is left atrial appendage occlusion, that's the name of the technology, a misnomer? I'm David Holmes. I'm the Scripps Professor of Medicine at the Mayo Clinic College of Medicine in Rochester, Minnesota. This article then that will be coming out relates to the fact that left atrial appendage occlusion, while that's a goal, may be a misnomer because some of the time we can't occlude it. So that will be the title of the article coming out in Mayo Clinic Proceedings. Left atrial appendage occlusion, ? A misnomer. We know that there are several important pieces of information. We note that, number one, the data from a study in 1996 by Mayo Clinic, Jacksonville, identified that in patients with non-valvular atrial fibrillation, 90% of the strokes were related to a clot in the left atrial appendage. At that point in time, we weren't sure what the other issues were, but we thought if that's where the clot comes from, potentially we could then occlude that structure so the patient wouldn't have the potential for having embolic strokes in the future. We knew that there were other reasons to have a stroke, and of course, if a person has a spontaneous bleed in the within the brain, a device like this wouldn't help. But the majority of large vessel strokes that we see, which cause the greatest mortality and morbidity, come from an ischemic source, and in non-valvular atrial fibrillation, 90% of the time, that comes from the left atrial appendage. And so at that point in time, we began to think about technology as well as the rest of the field based upon this initial Jacksonville paper by Joe Blackshear from Mayo Jacksonville. We began to work on strategies to close off the left atrial appendage. Out of this came several devices around the world, but the one that was furthest along happened to be the left atrial appendage occlusion device called the Watchman device. That was eventually, after a long period of time, approved in the United States in 2015. And since that time, its use has been dramatically increasing because the number of patients at risk for stroke with atrial fibrillation is very high. I have been involved in the Watchman device since its early application. In fact, the Mayo Clinic was the first institution to implant this device in the first patient treated in the United States back in 2002 or 2003 on Halloween night. And also, Mayo Clinic was involved in what was felt to be the 100,000th patient worldwide. That device was then implanted by Dr. Al Cooley, also in the catheterization laboratory at Mayo. So we have been involved with that from the very beginning of the technique of left atrial appendage occlusion. As you think about it, we would then say, if clot comes from the left atrial appendage, what we'd like to do would be to close off that appendage completely. And that's where the name of the device came from, left atrial appendage occlusion. That's the field of devices now. What, however, has become apparent is that for a couple of different reasons, we may not completely close off the left atrial appendage. That may relate to the fact that the origin of the left atrial appendage is oval, and all the devices are round. And if you put a round device into an oval structure, there's leak potential around it. That's one thing. The second piece is that maybe the devices are too small or aren't positioned just right, and that would then result in a leak. But what we have found is that perhaps 30% or even more patients have a persistent leak. When we look at that, we then say, gosh, the name of the device is left atrial appendage occlusion, but we don't occlude it completely. Does that matter? That's an important question. The surgeons have been involved with this in those patients that undergo coronary bypass graft surgery or other heart operations, and the surgeon ligates or truncates or takes away the left atrial appendage. They have found that in those patients that there is still residual flow into a stump of the left atrial appendage, that there is an increased risk of stroke or systemic embolization going forward. And so the field of interventional cardiologists has looked at this in one of the first trials. It was the first randomized trial in the United States. We found that leak was present in 30 or 35% of people. We then studied it further, and we found that it depended upon the leak size. In those patients that had a small leak, and the definition of that was less than 5 millimeters, that it didn't matter in terms of the long-term outcome. If there was a larger leak, there were more events. And so the field then went along saying that if indeed the leak is small, we don't necessarily have to do anything about that. But all of the data was based upon a small number of patients. Within the past year or 2 years, we've learned more information about it. Number one, we've learned that the leak size varies depending upon the device that is used. For example, in a recent trial using a different device called the Mayo device, the closure rate was better than with the Watchman device. And yet at 12 months, there wasn't any difference in clinical outcome of stroke and systemic embolism. You then look at that data and say, well, maybe leak doesn't matter. And so whether we say left atrial appendage occlusion, say that it's a misnomer because we're not able to do that all the time, or whether we do just fine was unclear. Just within the past year and a half, there have been 2 pieces of information that were important related to that. One was a report that came out of the left atrial appendage registry. The background of that is that when the device was approved by the Food and Drug Administration, the FDA said there needs to be a national registry of patients undergoing this procedure. It has to be all patients in the United States, except those that are getting a current investigational device. So it's a complete data set. And the numbers of patients in that have been climbing steadily. There was a recent analysis by Mohammed Al-Khuli from Mayo that looked at the impact of residual leak on outcome with the Watchman device. And they found that there was a small but clearly significant increase in ischemic events during follow-up, irrespective of the device size, leak. So our thought that small leaks didn't matter was probably tarnished by the fact that the number of patients that we evaluated was too small. There are lots of questions that this raises. Is it the size of the leak, or is it the type of the leak? Is it the surface area of the leak, or is it the systolic velocity of a jet across the leak? We don't know any of those pieces of information. But suffice it to say that leak seems to be important. And so although we call the devices left atrial appendage occlusion, they're sort of left atrial appendage occlusion with leak associated with it. There have been a whole host of strategies that have been used to evaluate that. For example, we now do a better job with some of the new technology, and so the frequency of leak has dramatically decreased. As we have different implantation techniques, and as we have a second generation Watchman device called the Flex device, in which the leak rate is less than 5%, even at 12 months. So that looks like it will be an important addition to the literature as we learn more about it. This specific device can be repositioned several different times. to make sure that you have the optimal position, because the goal should be complete occlusion. There will still be some patients that we don't achieve that goal. In that group of patients, there are a variety of strategies that have been developed. One of them, and we use that here as well as in other places, is to put in coils to close the leak, or to put in a variety of plugs to close the leak. Or now there is a strategy for using radio frequency energy to close leaks. All of these technologies have been performed in smaller numbers of patients. The results look good in terms of successful leak. Whether that is going to hold that closure device using a plug or a coil, or whether then there will be other leaks, is unclear. And in addition to that, whether the leaks, by closing them, will decrease the very small percentage of patients that have problems with the leak, is unclear. That will take very large trials. But at the present time, it's a rapidly expanding, terribly exciting field, as we see the number of patients in whom long-term anticoagulant therapy is still not felt to be optimal to reduce stroke in those patients with non-valvular atrial fibrillation. And so, although the use of the term left atrial appendage occlusion may not be the perfect name, because it doesn't always occlude the left atrial appendage, it's a device and it's a name that is here to stay, and we will see increasing iterations of approaches and technology that will more fully achieve the goal of complete left atrial appendage occlusion. It's a great pleasure to be able to visit with you about this. It's a terribly exciting technology, and it's an exciting technology not only from the patient standpoint, but from the societal standpoint, as well as from the professional standpoint, as it's a technology that will be used to meet and fulfill unmet clinical needs. Thank you for the chance.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.